From Microbe TV, this is Infectious Disease Puscast episode. Is it episode 50?
It is episode 50.
Oh my gosh. Oh my gosh. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara Dong. Welcome to our 50th Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. So, of course, that's our little banter for today.
Yeah, I mean, we don't want to banter too much, but yes, oh my gosh, 50 episodes. That's, wow.
It's you have to find little things to celebrate. I think it's pretty exciting.
Well, with this, like every 2 weeks, it's, we're not gonna hit 100 for, another 2 years.
Yeah. But it does mean, I guess, that we're approaching 2 years pretty soon, which doesn't even seem like it could be true. All right. Well, Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we? I will open up our viral section. Please remember to listen to This Week in Virology TWIV and TWIV clinical updates. I pulled a paper about ongoing measles in the developed and developing world, which unfortunately is particularly relevant recently. This is from JPEDS, from Dr. Cherry, who's at UCLA and one of our author of one of our important pediatric ID textbooks. This is just a very nice, succinct overview of the history and clinical manifestations of measles. Hopefully everyone has been sort of reviewing that recently. I found out something that I didn't know. I was surprised that the first recorded epidemic of measles occurred in Boston. Never knew that. I think I can also summarize by just sharing the beginning of the discussion. So this is a quote. Contrary to the beliefs of the anti-vaccine lobby, measles is bad. In acute measles, the death rate is 1 to 3 per thousand, and the risk of encephalitis is 1 per thousand. Delayed complications include SSPE, so subacute sclerosing panencephalitis, and post-measles immune amnesia. So as a reminder, in PSA, 1 dose of measles vaccine in exposure situations will prevent 95% of cases. 2 doses will prevent 99% of cases. So again, a refresher is necessary given the numerous outbreaks. And although we wish to tell children who are too young to vaccinate or don't have antibody to measles to not travel to high-risk areas, I think, unfortunately, where a, quote, high-risk area is expanding and increasing and becoming just sort of typical locations.
Yeah, no, this is painful news. I know I'm going to actually spend a bit on This Week in Virology Clinical Update, dropping this Saturday, probably before this, just the production time. But yeah, just talking about what a tremendous problem we already have here in the United States. Yeah. Well, in the same sort of vein, worth mentioning is a recent article in the Pediatric Infectious Disease Journal by Stanley Plotkin. And it is titled, We Need a New Mumps Vaccine. In this article, really, it's an opinion piece. Dr. Plotkin points out that we do see cases of mumps in vaccinated individuals, typically college-age adults, and he calls for the development of a new, improved vaccine. He discusses how the current mumps vaccine that's in the MMR carries an HN protein of genotype A, whereas the circulating mumps viruses carry an HN protein of genotype G in certain areas, particularly the US. Also, the waning, as we like to say, contraction of antibody levels over time leading to diminished protection, suggesting that a boost in some situations might be reasonable. And it's all very interesting, and I think sort of reminding people that there are 8 different genotypes of the mumps vaccines, and sort of the history of, we started with serotype and those serum institutes, right? And then we've moved to genetics now. But the whole idea that different regions have different mumps genotypes, serotypes. And so maybe it's time to move with not just a quadrivalent, but maybe an octavalent. But unfortunately, it does seem that we are seeing the return of vaccine-preventable illnesses And we're going to have to start revisiting a lot of these topics.
Yeah. This is an update that was published in JAMA, updated treatment recommendation on the use of cabotegravir and rilpivirine for patients with HIV from the IAS USA guidelines panel. So the most recent IAS USA treatment guidelines noted the study of long-acting injectable cabotegravir rilpivirine, but didn't recommend it at the time in the setting of viremia. Since then, there have been some additional studies of rilpivirine in people with HIV viremia due to difficulty taking oral ART. So based on this accumulating data, the panel has now provided a revision. When supported with follow-up and case management services, cabotegravir rilpivirine may be considered for people with viremia who meet the following criteria. 1. Unable to take oral ART consistently despite extensive efforts and clinical support. 2. High risk of HIV disease progression. So CD4 under 200 or a history of AIDS-defining complications. 3. Virus susceptible to both cabotegravir rilpivirine. And 4. Referral for treatment of substance use disorder and or mental illness as applicable.
All right. Well, the article Genetic Susceptibility to Astrovirus Diarrhea in Bangladeshi Infants was recently published in Open Forum Infectious Disease. Now, why do I like this article and why did I include it? What I find interesting is that in this investigation, the authors identified 2 significant host genetic regions that may influence astrovirus diarrhea susceptibility. So the authors performed a genome-wide association study of astrovirus infection in the first year of life from children enrolled in 2 Bangladeshi birth cohorts, and as mentioned, found host genetic susceptibility loci for this infectious viral disease. So I have in my head a day when we will get a full sequence of our genome, and this is then part of the medical record that will help with the diagnosis of what ails us. And they have a nice, what is this, graphical abstract where they've got a little thing of the Manhattan plot with the 2 genetic loci shooting up, and then the comparison of cases and controls with regard to diarrhea. But, maybe this will be the day of AI and you'll get the history and then AI will sort of jump in with, based on the genetic sequence, this person's risk, will be adjusted accordingly for their genetic susceptibility.
Hopefully that's further away than we think. So I pulled a paper from The Lancet, Long-Term Efficacy of a Recombinant Hepatitis E Vaccine in Adults, 10-year results from a randomized double-blind placebo-controlled phase 3 trial. So currently, the hepatitis E virus, HEV, I'm probably going to say Hep E because I find it easier to say, Hep E 239 vaccine, Hekelin? I actually don't know how to pronounce it, is the only available vaccine for Hep E, and it was shown to prevent infection with efficacy of 100% during 12 months after the 3rd dose in a large-scale randomized double-blind placebo-controlled phase 3 trial. So this is a look at the follow-up long-term efficacy on the basis of a 10-year extended follow-up from that phase 3 trial. So this is conducted in Jiangsu, China. So there were almost 113 participants who were enrolled. So that's about 56,000 in the vaccine group and approximately 56,000 in the placebo group, along with 178,000 residents in the study region who were considered an external control cohort. In that group, they found 90 people with Hep E. 13 of those were in the vaccine group, 77 in the placebo, and then they had 325 people with Hep E in the external cohort. So the authors found in this 10-year study period, so this was 2007 to 2017, that immunization with Hep E offered durable protection for up to 10 years, with vaccine-induced antibodies against Hep E persisting for at least 8 years. The efficacy of the 3-dose regimen was 86.6% compared to placebo and 90.6% compared with the external control cohort. So another kind of few additional notes. For the cases in the vaccine group where they actually had Hep E, those patients did have less severe disease, at least in terms of ALT elevation and duration of symptoms. And there was also a subgroup that only received 2 doses and had a clinical efficacy of 100% within a 30-month period. So this might be sort of a useful approach in the event of an epidemic. Overall, though, the total number of hepatitis E cases does seem on the lower side. Maybe the exposure in this population was a little bit limited. So I think there's some question of would this translate differently in the setting of a large outbreak? And one other drawback is that, of course, information on vulnerable populations like pregnant patients and those who are immunosuppressed is limited. But overall, that's exciting news about the vaccine.
Okay, worth a mention is the article Association of Tecovirimat Therapy with Mpox Symptom Improvement, a cross-sectional study, King County, Washington, May through October 2022, also published in Open Forum Infectious Disease. Maybe that's the place where people like to publish. We'll see. That reinforces the importance of timing when it comes to therapeutics and infections. So in this study, the investigators compared individuals who did not receive tecovirimat to participants who started tecovirimat early. So this is 5 days or less from symptom onset, and late. So that's, you miss that 5 days, but you're still getting it in less than or equal to 28 days from symptom onset in their illness. They found that median time to symptom improvement did differ with early tecovirimat compared to no tecovirimat, but not with later tecovirimat compared to none. So if you miss that first 5-day window, it just looks like you're not going to make a big difference with tecovirimat. And the reason I thought this was important were a couple things I'm going to say. So one is, again, just reinforcing the time for an antiviral is in that first 5 to 7 days. We maybe learned this from many things, including COVID, influenza, et cetera, et cetera. But also that, as we can see here, some people who don't get that early treatment, they can have really extended duration of symptoms.
All right. Well, we will move into our bacterial section. Please be sure to listen to This Week in Microbiology. I really love this review. It's from CID. Nosocomial infections in adults receiving every time, Dan. Extracorporeal membrane oxygenation, ECMO. A review for
I
ID
think
clinicians.
ECMO is the easiest way.
Every time. Authors here provide a nice overview of epidemiology, including some challenges like how NHSN excludes patients receiving ECMO from things like vent-associated events and central line-associated bloodstream infections. It's kind of hard to have surveillance on those. The greatest risk factor, at least in the single center studies, has consistently been duration of ECMO, which I think makes sense. Figure 2 is a nice overview of factors associated with increased infection rate and broken into the buckets of ECMO-related, patient-related, stewardship, and infection prevention factors. They also talk a little bit about the literature available on prophylaxis and infection prevention. And figure 4 is a proposed algorithm for the workup of suspected ECMO-related infections. As you can tell from the paper and probably in practice that there's pretty variable practice patterns on how people approach these infections. And I think a take-home from this statement, which I'm pulling directly from the paper, with the inflammation associated with ECMO and the low specificity of individual biomarkers, there is no current specific combination of biomarkers with a high degree of certainty in determining if a patient receiving ECMO has a secondary infection. Therefore, inflammatory markers such as CRP or procalcitonin should not be used to guide infectious workups. So I encourage folks to check this paper out.
Yeah, this is a challenging topic. I know that we've talked about lately in my group is this issue about making the diagnosis of a lot of these nosocomial infections, right? So trying to, dare I order a blood culture on someone with a central line and risk my institution getting labeled as having a CLABC. And I really think this is something maybe our societies need to address. I understand wanting to reduce the incidence of central line-associated bloodstream infections, but you don't reduce them by not looking for them. So I think this is important data. We need to actually go ahead, and if someone is febrile and they have a central line and we're concerned about a central line-associated bloodstream infection, we should look for it. We should actually be able to have microbial-directed therapy for CLABSIs, for C. diff, for CAUTIs, et cetera, et cetera. So just a call to arms for all of those of us that took an oath. Anyway, the article, does paging clinicians about tick-borne disease serological results impact clinical care? A retrospective analysis of 70 cases in North Carolina, recently published in the American Journal of Tropical Medicine and Hygiene. And here they found that a high proportion of cases, about 40%, were not prescribed antibiotics until the results were available. But the vast majority of these cases did not have evidence of compatible symptoms or disease progression. These findings suggest that paging may have prompted unnecessary treatment. And I know this is our world of now where, you get paged and the patients see the results right away and they want real-time response, but just really reinforcing that it can be complicated and you really want to sit down. You want to get that history. You want to think about it. You don't want to just be throwing out those unnecessary antibiotics. You want to treat infections when they're relevant, but you don't want to just treat lab values.
This next paper I pulled from JID, Metabolomic Characteristics of Non-tuberculous Mycobacterial Pulmonary Disease. So metabolomics is the quantitative measurement of metabolites in individuals in response to genetic modification or environmental stimuli. The goal is to depict host responses to a pathogen and try to better understand those host-pathogen interactions. So in this paper, authors in South Korea, where prevalence of NTM infections have increased significantly, studied metabolite features of NTM pulmonary disease through this type of analysis. So most patients were female. The mean age was 61. 18% had positive AFB smears. Cavities were present in 10 or 20% of patients. And organisms included MAC, M. abscessus, and M. macilliensis. I don't know if that's how I've said it, but I don't actually know if it's right.
I pronounce it that way, macilliensis.
Okay. About 45% had mild disease, 45% had moderate disease, and 9% had severe disease. So just to give you perspective on the patients that they looked at. So they found that 11 metabolites, including leucine, tyrosine, inosine, proline, 5-oxoproline, hypoxanthine, they found these 11 metabolites with high confidence levels that distinguish patients with NTM pulmonary disease from healthy individuals. So sort of unique, specific metabolic clusters. Then they constructed classification models using machine learning, which had the ability to distinguish patients with NTM pulmonary disease from healthy controls. There was also a non-NTM disease control group with 60 patients of bronchiectasis, which they used to try and help strengthen the specificity and reliability of the outcomes. And then lastly, they demonstrated that these metabolites play important roles in maintaining the balance between reactive oxygen species generation and antioxidant activity. So some of the metabolites I mentioned were elevated, meaning more oxidative stress, and then the antioxidant metabolites were less abundant. So I thought this was really interesting, gives us some novel insights. We all know that NTM are abundant in the environment, and so trying to answer the question of why some individuals may be more at risk. This doesn't directly correlate metabolites with clinical parameters, but is the first study using this approach of serum metabolomics for NTM disease.
Very cool. The article, a machine learning-based risk score for prediction of infective endocarditis among patients with Staphylococcus aureus bacteremia. The SABIR score was published in JID. This study utilizes a retrospective big data analysis from territory-wide electronic data and included hospitalized patients with SAB, Staph aureus bacteremia, between 2009 and 2019. They determined the areas under the curve of the receiver operating characteristic, the OCROC. What is that? Well, the OCROC, or ROC, it's a binary classifier model. So one looks at a binary yes versus no questions or characteristics, and then plots true positive rates against false positive rates. So they identified 15,741 Staph aureus bacteremia patients. Among them, 4.18% had Staph aureus infective endocarditis. They go ahead and do these OCROC scores. So the OCROC was 0.74 with a negative predictive value of 0.98. Now, the four most discriminatory features were age, history of infective endocarditis, valvular heart disease, and being community onset.
All right. I have a journal article from CID, 18F FDG PET CT, and radio-labeled, this is a very long title, radio-labeled leukocyte SPECT CT imaging for the evaluation of cardiovascular infection in the multimodality context. ASNC imaging indications, series expert consensus recommendations from, alphabet soup, ASNC, AATS, ACC, AHA, ASE, EANM, HR, IDSA, SCCT, SNMMI, and STS. Oh. Okay, so this is the first in this. So that ASNC imaging indications are like I-squared series. Basically, the goal here was to take a look at the role of PET CT and SPECT CT and use a Delphi approach, because as many people know, these studies, meaning PET CT and SPECT CT, have been incorporated into several of our guidelines for cardiovascular infections, but often without addressing sort of the specific clinical scenarios of when to use it. And so how do we use these tests? And I'm not going to go through the details to keep it brief, but I will refer you to Figure 1, which provides an algorithm for suspected native or prosthetic valve infective endocarditis or prosthetic material / VAD infection, as well as Figure 2, which is an algorithm for possible cardiac implantable device infections. They also have a really nice section at the end where I think it's 5 cases, maybe it was 6 cases, where they sort of give examples, representative images, sort of how they use these recommendations. So I thought this is a really nice resource. I can imagine it took a really long time for everyone involved. So hopefully people can reach for this when they're struggling with, whether we should recommend that nuclear scan. All right, and I'll roll us into the fungal section. So the first one I have is from OFID, serial bronchoalveolar lavage, BAL, fluid, Aspergillus galactomannan, and treatment response in invasive pulmonary aspergillosis. So this retrospective cohort study found that trending BAL galactomannan in IPA, invasive pulmonary aspergillosis, does not always correlate with treatment response. They found it was concordant in only about 60% of patients. So they took a look at patients with a positive BAL galactomannan at diagnosis who were on antifungal therapy and had at least one follow-up BAL galactomannan within the window of 7 to 180 days after diagnosis. So 218 patients were initially identified with a positive BAL galactomannan, but 168 were excluded, mostly because they didn't meet criteria for IPA. So there were 50 patients ultimately in the final group. They were considered test positive if the ODI value was greater than or equal to 0.5 based on the manufacturer recommendations. I will note that the cutoff of 1 was adopted in the updated definitions for IFI. So the median value at diagnosis of this galactomannan was 3.68. The follow-up galactomannan was collected at a median of 32 days. So trending these tests are unreliable markers for treatment response. I think the flip side that some people might also interpret this study is that patients who had stable or increasing values were commonly associated with clinical failure. So I could see how you may look at it and be disappointed that it wasn't helpful, but you may also interpret this as, oh, well, we don't have many alternate markers of response, and maybe it is helpful to know if someone has uptrending or stable BAL-galactomannan. It probably depends a little bit on your practice and how often you're collecting this test. But I thought that was interesting. And then I pulled a case report from Transplant Infectious Diseases, voriconazole inhalation powder, a novel therapeutic alternative for invasive pulmonary fungal infections. So this report shares the first use of Vori inhalation powder, or VIP, which is a great acronym, to treatment of pulmonary mold infections. So they gave 2 lung transplant recipient examples that the first patient was a 50-year-old male with a bilateral lung transplant. Sounds like had a lot of complications, anastomotic ischemia and stricture, acute rejection episode, and chronic lung allograft dysfunction, and has had recurrent infections with Aspergillus fumigatus, Scedosporium, and Lamentaspora, despite 16 months of poorly tolerated POSA. So this patient received VIP 80 milligrams twice daily through a dry powder inhalation device for 6 months, had no major adverse effects. The serum Vori trough was below the limit of detection except for 1 check. The other patient was a 54-year-old bilateral lung transplant recipient with CLAD and multiple fungal infections, previously on POSA, also received VIP twice daily, but for 3 months and had improvement. So I actually didn't realize that there's been some prior case reports of nebulized voriconazole that had some challenges like systemic absorption, although lower than oral absorption, and poor tolerance based on, sounds like, unpleasant smell and taste and bronchospasm and so on. So I put a picture because they provided one of the dry powder formulation handheld device. And I used to work in a allergy asthma clinic and have to show people how to do inhalers. So this gave me some little flashbacks. But this dry powder formulation has been assessed in mouse models previously, but this is the first reported use in humans. So would be appealing if we could use this for things like prophylaxis or isolated pulmonary infections, or when systemic azoles have challenges. But of course, we need more studies on clinical efficacy.
All right. Moving us into parasitic, be sure to listen to This Week in Parasitism, the article Post-Surgical Outcomes of Mesial Temporal Lobe Epilepsy Due to Hippocampal Sclerosis Associated with Calcified Neurocysticercosis was recently published in the American Journal of Tropical Medicine and Hygiene. Now, for background, the authors start by suggesting that neurocysticercosis is the most common parasitic neurological infection and a noteworthy etiology of epilepsy in developing nations. Here we read the results of a retrospective cross-sectional study that was conducted in 89 patients with mesial temporal lobe epilepsy with hippocampal sclerosis who underwent anterior temporal lobectomy between January 2012 and December 2020 at a basic epilepsy surgery center located in Lima, Peru. Most of the patients were free of disabling seizures at 1 and 2 year follow-up, demonstrating better outcomes than the non-surgical patients, with 94% reintegrating into work or education. So very encouraging results there. All right, and moving us into miscellaneous, we've got a few here. The first, a topic that people who listen to me may have figured I would find interesting, the effect of neutrophil to lymphocyte ratio on prognosis of elderly patients with severe sepsis combined with diabetes mellitus, published in BMC Geriatrics. This is a retrospective analysis of 162 elderly patients with severe sepsis with diabetes, broken down into a survival group, and that's an N of 104, and the death group, N of 58, according to 90-day prognosis. The number of neutrophils, lymphocytes, and the neutrophil-lymphocyte ratio were compared. In the survival group, neutrophil counts and NLR were much lower than those in the death group, while lymphocyte counts were much higher. We've got a p-value of less than 0.05. The ROC curves, remember that, showed that the optimal cutoff value for NLR to predict 90-day mortality combined with diabetes was 3.482. Let's just say 3.5. And they have a really nice, you can really see how this separates out. The interesting thing is that it separates out at day 40 and then really separates from there. So just pointing that out. Let us wrap things up with an exciting article. Maybe this is the high point of our the article, Impact of the Febrile Podcast and Learning Resource as an Infectious Diseases Education Platform, published in Open Forum Infectious Disease. Now, this is an article about a podcast. What would be better than the podcast or the article, right? You know, like when you're going to watch a movie and you're like, what was better, the book or the movie? What was better, the article or the podcast? Well, I should point out that the first author of the article is the person behind this podcast. So we'll keep an eye out for any.
For the record, I did not tell Daniel to do this.
Well, as the authors, Sara, did one of them tell us, Febrile is an infectious disease podcast and learning platform with the aim of providing high quality and accessible ID content for learners. In this article, they describe the utilization of Febrile as a resource for learning and teaching ID, as well as learner satisfaction and perceived impact on clinical practice. For some background, this podcast, Febrile, was launched in December 2020 and includes audio podcast episodes, infographics, and detailed online summaries of adult and pediatric ID topics. In this article, they summarize production and contributor information. Podcast, website, and social media engagement is reported from available quantitative analytics. An online anonymous survey was conducted to assess educational impact. On to the results, shall we? We read that after only 3 years of operation, this podcast, Febrile, the brainchild of an infectious disease fellow who now is an adult infectious disease attending, has produced 90 episodes and has been downloaded almost 500,000 times in almost 200 countries. A total of 230 participants from 30 countries and 38 U.S. states completed the survey, of whom 34.5% were ID fellows in training, 34.2% were ID faculty physicians. I don't know who the other folks were. 72% of survey respondents reported visiting the website, and 82% had seen an infographic. Enhancing core ID knowledge was the primary driver for learning. 2/3 of respondents indicated that information learned from Febrile had changed their practice, and 50% had used Febrile as a way to teach others. Febrile also led to favorable impressions of ID for those considering ID as a career. Now, I love, and yes, I agree with the author's conclusion, Febrile is an engaging platform for ID medical education and provides a unique resource within the global ID community. Great graphical abstract, and I love Figure 1. I will also leave a link to the website. Maybe these authors want to publish something on the great podcast from Microbe TV, including the ID Postcast.
Well, we do need to translate digital scholarship into more generally accepted scholarship. Thanks, Daniel. This is like the summary of the past 3 years of my life. It's probably the thing I've spent the most time on, maybe even more than sleep. So getting this through to share with folks. And hopefully some of the people who are listening are actually the people who probably filled out the survey. So I guess I should also give a thank you for that. And thank you to you for being a supporter and, you know, inviting me to be on Puscast. Feel pretty lucky. All right. Well, that brings us to the end of this Puscast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts or grab it with your favorite podcatcher. We'd love to get your questions, comments, and paper suggestions, so send them to puscast@microbe.tv. If you like what we do, consider supporting these science shows of Microbe TV at microbe.tv/contribute or parasiteswithoutborders.com and click on the donate button.
I'm Sara Dong. You can find me at swindong, at Febrile Podcast, or at febrilepodcast.com.
And we'll leave in like one of those QR codes in the link so you can go right to the Febrile podcast. All right, I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.